Greetings, everyone, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around our country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this very episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. If you have not subscribed to Bright Spots in Healthcare, the podcast, I encourage you to do that right now. Go to whatever podcast app you like best, type in Bright Spots in Healthcare, click subscribe, leave some feedback like this one from Dr. Kin Jaden, quote, "Great guests that help promote problem solving and public health. Thank you." It's comments like this, ratings, that allow more of us in the industry to find this show and get access to the great guests like the ones you see in front of you today, and tap into all of their great expertise. Today's episode is going to talk about navigating the intersection of health equity and chronic disease. Our partner for today's episode is Vori Health. Vori Health is a specialty medical practice delivering a virtual first musculoskeletal solution to help members get back to their lives faster. They are the only nationwide MSK practice with a doctor-led care team and have an advanced approach to whole person care that we'll talk about a little bit later. And in my opinion, not theirs, this is a model that could be reapplied to almost any chronic condition. I'll tell you a little bit more about their approach and their organization later on in the show, but if you're curious, you could check them out right now at vorihealth.com. That's one word, VORI health.com. All right, I have divided this episode into sort of three segments here. We're going to first talk about strategies tied to education, both the employee or the member and the provider. And then we're going to shift over to talk about consumer centricity and how you think about the consumer first. And then we'll end the episode talking about getting local, boots on the ground, partnering with the community. All of that ties to that intersection of health equity and chronic disease. And we have an incredible roundtable of guests for you today. I am going to not take the time to introduce them formally. Our producer, Sherry Keels, is going to post a link to their bios right in the chat and in the show description if you're listening via podcast. We will quickly mention their names and titles, and I'll reintroduce them when I bring them back into the interview and the conversation. Our first guest is Nebeyou Abebe, Senior Vice President, Social Determinants of Health, Highmark Health. We also have Dr. Joneigh Khaldun. She is the Vice President and Chief Health Equity Officer at a small organization you might have heard called CVS Health. You could Google them. We also have Mary O'Connor, Dr. Mary O'Connor, Chief Medical Officer and co-founder at Vori Health. And last and certainly not least, Dr. Kelli Tice, Vice President of Medical Affairs and Chief Health Equity Officer at a small, little-known regional plan called Florida Blue. So welcome all to the show. Super excited to have you here. Joneigh, I'm going to start with you. And get the CVS perspective. I mean, a massive company like CVS Health, how do they take on health disparities? And if there's sort of a chief health equity officer listening right now, and they were given a clean slate and reasonable resources, like how would you advise them to go ahead and start an entire strategy around reducing health disparities?
Yeah, well, first of all, thank you for having me in this conversation today. Really looking forward to speaking with you and my fellow panelists. I think it's important actually to start with definitions. Very generally, health equity means that everyone has a chance to have optimal health and really to thrive. So the way I describe my role in the organization is, when we think about CVS Health, the 120 million people whose lives we touch every day, the products, the programs we develop, the communities that we're in, my job is really to make sure that we are showing up in a way that where we provide care and those services in a way that leaves no one behind, regardless of their background or their circumstances. So I would say to any new chief health equity officer out there, really start by learning about your organization. What are the key value drivers in your company? What services do you provide? Where are there opportunities where your organization is, I would say, uniquely suited to move the needle or fill a gap in addressing disparities and inequities? And then I think this is really important. You've got to get really, really intentional and very specific and focused around what you're trying to accomplish. And so that's what I've been in my role at CVS Health for about 2.5 years. And so we do have a 3-pillar strategy that I'll talk about briefly. The first pillar is around empowering our people. So we have actually over 300,000 colleagues who work at CVS Health. So really, this pillar is around how do we really make sure that we make sure whoever you are, that you have the skills, the tools, the knowledge to advance health equity, whether you're working in our front store, whether you're a clinician providing direct services, whether you're doing an operational or administrative role. Can we make sure that you have the skills that you need to understand disparities and inequities in your line of work? As part of that, we've launched several key initiatives. One is a series of trainings for all of our colleagues, regardless of where you work in the company. It's an online learning module that provides a general overview of our health equity strategy, but specifically how inequities exist and what we're doing about it as a company. We also have a series of learning, continuing medical education modules for our clinicians. So our internal pharmacists, nurses, doctors, but also our external provider networks on things around mental health and chronic disease. We actually have over 20 CME modules that we've launched actually over the past 6 months or so. So that's our first pillar. Our second pillar is around data. So measuring what matters. We're really being very intentional about increasing, standardizing, and improving the quality of both demographic data, but also social determinant of health data so that our programs really meet the needs of the people who we're serving. And then finally, take bold actions. And this goes back to what I said around getting very specific. So we actually chose initially 2 specific health areas: hypertension and depression. We know the prevalence, we know there's disparities, and we know the significant morbidity and mortality associated with it across our company, across the country. And so we actually have very specific programs across the company where we have identified racial and ethnic disparities among our members and our patients. We've actually tailored very specific interventions so that hopefully we see those disparity gaps close over time. So again, understanding your organization, understanding what levers you have, and then getting very intentional and focus is what I would tell any chief health equity officer out there who's new in their role.
I love this. I want to see if I was listening here, so you could grade me. So first of all, the question that your strategy sort of answers, which I love, and I'm going to use this a lot even after this show, so maybe I'll give you credit, is how do we not leave anyone behind? You just think that simplifies the challenge right there. And your strategy at CVS Health starts with empower the people. You mentioned 3 pillars to your strategy. One is around educating your employees through training modules and also educating your providers through CME. You also mentioned data, measure what matters. John Doerr's book, Measure What Matters, would probably take take a little royalty there. And then 3 is bold action, and you guys are focusing some of your bold action tied to hypertension and depression.
That's right. You've got our strategy.
Awesome. Great. That's super, super useful and a great way to kind of get us started here. I want to stick with providers for a moment here and bring in Nebeyou Abebe. He's the Senior Vice President, Social Determinants of Health at Highmark Health up in the 412 and beyond. I wanted to bring you in and talk about, how are you educating your providers, but also enabling providers to execute? Like, how are you reducing the headwinds? We know how hard it is for our fellow doctors who are on our panel to, fit new things into the workflow. So how are you able to allow your providers that you're working with to take action on SDOH and quote, not leave anyone behind?
Sure. Well, Eric, I also want to thank you for the opportunity to present and share our story with you and your guests. And also I'm very proud to be serving on this esteemed panel. And so to answer your question, with Highmark being one of our nation's largest integrated healthcare delivery and financing system, really affords us the opportunity to do transformative work at a much faster pace than most organizations. And so, many providers and payers are working on screeners. But what really sets our work apart is that we started our journey in creating a universal SUH assessment back in 2019. And so, we've implemented it across our provider and payer system. And most importantly, as you noted, we've integrated it into our clinical workflows. And so to date, we've conducted over 1.4 million assessments to identify health-related social needs of our members and patients. In addition, to our assessment, we've also integrated our resource and referral platform called Highmark Community Support, which is powered by Find Help, into Epic. And so it makes it seamless and easy for our clinicians and providers to assess and then refer patients and members to social care interventions. So myhighmarkcommunitysupport.com has been used to search for local resources such as food, transportation, housing, et cetera, over 500,000 times since we've launched. And so with respect to how we use the data, the assessment data we collect is used in a variety of ways. For case management and patient care, prior assessment results are visible to them, to clinicians and case managers at the point of care to guide clinical decision making. Also, positive assessment results also trigger social care programs and referrals to community benefit organizations via the community support platform. And lastly, we follow up on gap closure and maintenance for individuals with repeat positive assessments. From a research and analytics perspective, we can train predictive models to estimate overall and domain-specific SGOH risk for our entire population. These estimates are also used in opportunity assessments and solution design and activation. It also contributes to the evidence base, right? Connecting SGOH factors to specific chronic conditions like diabetes or hypertension, et cetera, utilization and expenditures through scholarly research and publication. And I would say, one of the keys to adoption, because to your point, many doctors are just extremely busy and don't want to add another thing to their plate. To Joneigh's point earlier, very intentional work with clinicians, both on the plan side and the provider side. And I can tell you that, clinicians and providers are saying that we're helping them bring joy back to the practice of healthcare because they're not just focused on the physical health of their patients, but with the addition of social health data and other data, we're actually able to give them a full view of the health and well-being of their patients. And we're empowering them with tools and resources and programming for them to actually act upon them, right? And so now we're in a position in our journey where we're beginning to share and spread our learnings to other provider systems where we work closely to help them go faster, not make the same mistakes we have made, and move together towards a more integrated care model across social, behavioral, and physical health.
Right. This was a lot of good stuff. I'm going to try to unpack and summarize it. Keep me honest here. So the first thing and the foundation to all of this working is the universal SDOH assessment, where you guys started in 2019. You've got over almost 1.5 million, just under 1.5 million assessments already done. So that's number one. Then the two is to integrate that into the clinical workflow. And you do that through a platform that you guys built that you call My Highmark Community Support. It's powered by Find Help, and you integrated it into Epic, which of course is probably the most critical step to making it enabled for providers. Then you created a visible, I don't know if it's a dashboard at point of care, and there's automatic triggers via the platform that allows the physician to see things that are important for follow-up. It gives an SDOH risk assessment that I'm sure it happens on the back end that points the provider to understanding the risk and ties it to potential chronic diseases. And then the other thing you said that was super important to making this all work is, and you didn't use these words, but you brought in the clinicians as you launched this program and got their buy-in, and maybe you didn't say this verbatim, but their contribution into this entire program.
Yeah.
And so it allows them to get this holistic view of the well-being of their patients. And as doing so, you're bringing back a little bit of the joy back into why they got into this business in the first place.
You got it, Eric. Yep.
It's great. I wanted to, it's perfect. We're going to now segue into the patient. I like saying the consumer of healthcare. And when it comes to health equity, what do you do to think about the consumer beyond the obvious, race, gender, disability, et cetera? So to answer that question, I'm going to bring in our surgeon, Dr. Mary O'Connor. She's the Chief Medical Officer and co-founder at Vori Health. So how do we answer that, Mary?
Thanks, Eric. My answer is that we really have to think about the values and preferences of the individual patient or consumer, right? And focusing on what matters to them, not what just is the matter with them. And that helps us not just look at social determinants, which are very important, but also to personalize it to their individual preferences and values. And I'll illustrate this with a story. So we saw a woman named Joneigh, 69 years old, on Medicare Advantage, low income. A few years ago, she actually injured her back when she was lifting a patient. She was working in a skilled nursing facility. She had some physical therapy, some initial improvement, but like so many patients, developed recurring low back pain. So she subsequently retired from her job, but she had lots of personal stress in her life. She cared for her sister, and many of her grandchildren actually lived with her. She was obese, diabetic, hypertensive, gastroesophageal reflux disease. So this is, a common kind of pattern we see with patients with musculoskeletal conditions and other comorbidities that impact their condition and also are important to address in terms of their overall health. So she didn't have time. She didn't have time to go see a physical therapist. She couldn't afford copays. So the partner that we were working with, copays were waived. We were able to engage her through our virtual platform. So she saw our physician, physical therapist, health coach, registered dietitian, and we started her on a plan of care that focused on what mattered to her, not just her back pain. And I'm going to tell you what she said mattered to her. She said, I want to lift up my family members. I want to be able to do that without pain. And I want to be able to walk my pit bulls. Okay. So we saw her for 6 weeks. She had a total of 7 PT visits, physician visit, 5 health coach visits, an RD visit. Of course, we're engaging her asynchronously through messaging and chat, and she did really well. She was able to embrace the program because it was so convenient for her and literally report that her initial severe 10 out of 10 low back pain could be 0 on some days, and on her worst day, it would be 1 to 2. She was able to increase her level of physical activity. She was working on healthy eating, starting to lose some weight, and just really pleased with her outcome. And I think more importantly, engaged in an ongoing journey for her to improve her health. And I think the reason why we made such a difference for her is because we really focused on what matters to her. And the whole care plan was focused on that. Then we asked her actually why she thought, what was different about her experience with us. And here she said, you listened to me more than previous doctors and therapists. You gave me health coaching, which I had never been offered before, and you made it easy for me to see you. So I think it's really important that when we recognize that marginalized patients, as a general statement, don't feel that their voices are heard by their clinicians, that is a very important place for all of us to start in terms of addressing health equities and health disparities, and to, again, surround these patients with the care team that's going to empower them to make positive lifestyle changes, which for us greatly impact our ability to provide effective non-surgical care, right? Because we're trying to help people get the right care.
Love that. All right. I'm going to summarize it. We had the key to this whole program working. It sounds like it starts with the whole premise of what matters to the patient, what matters to her. And once she defined that, that allowed the team to execute on a plan. And that leads to the second thing that I captured here, Mary, and that is you need to have a holistic care team. You mentioned the 6 weeks that this 69-year-old woman was in the program. She had 7 PT visits, 5 coaching visits, a doctor's visit. I think I missed something else that you said.
Registered dietitian.
Registered dietitian, right? So like there's boom, that's 1, 2, 3, 4 different care providers. And so those are the two key pillars to the program. And ultimately that resulted in the consumer feeling heard and making it much easier for her to access care. At the end of the day, you put those together and health disparities begin to shrink.
Exactly. Along with all other tools that have been mentioned that are important, but at an individual clinician level, what can an individual clinician do? Listen better and recognize the importance of the patient's values and preferences.
Yeah, we're going to get into that a little bit more. I want to come back to that. So everyone put a mental note. We're going to come back to that. I want to move now over to Dr. Kelli Tice. Before I do that, it strikes me there was an article I read in preparation for this, co-written by Dr. O'Connor and another doctor, Dr. Carrie McCullough, around when pain divides us and how to solve inequitable access and outcomes. And they use MSK, of course, as an example because that's where they focus. But it's applicable to different chronic illnesses and states. So if you want a copy of that, it's really mostly informational. It's a little bit branded with Vori. I'll forewarn you, but it's really mostly content, or I won't be offering it up. I'll send it to you directly as a PDF if you guys want that following the show. So we could put that right up there. Oh, look at that. We got a new image there, Sherry. You're raising the bar and how we do these polls. That's great. All right. So Kelli Tice, Dr. Kelli Tice, Vice President of Medical Affairs and Chief Health Equity Officer at Florida Blue. Kelli, can you provide an example how you guys in Florida Blue are thinking about the consumer and creating more equitable access into the healthcare in all your markets?
Sure, and I echo the comments of my co-panelists. Really grateful to be a part of this conversation and already so intrigued by the things that are being shared. The example that's top of mind for me is really in the area of maternal health equity, which has gotten a lot of well-warranted attention in recent months. And one of the things that we have chosen to do is work to align the work that is done sort of on the philanthropic side of the house, the things that are happening out of our Florida Blue Foundation, to be certain that those same initiatives and efforts are aligned with what we're doing in our care programs. And one of the things that's valuable about a Chief Health Equity Officer position is this opportunity to see across the enterprise and initiatives to bring alignment, sort of pull the thread through, as I like to say. So one of the things that we've done is take a partner that we initially identified through some community funding that came out through our foundation and really elevate their ability to impact this issue of maternal health equity concerns. And that was the Preeclampsia Foundation. It actually happens to be based in Florida. And they were looking for an opportunity to expand their reach. They had long functioned in a way that was focused on elevating the clinician and patient relationship. So they were leveraging that relationship, but they were deploying blood pressure cuffs to high-risk moms, but they didn't have a platform or the opportunity or the funding to be able to do that on a large scale. And so what we were able to do in partnership with them and our largest provider of women's health services that does, tens of thousands of deliveries for our member population annually, connected the two, and we're deploying 2,500 blood pressure cuffs to high-risk moms. Now, the way that's being done is through leveraging the data that we already had available to us through a social determinants of health dashboard that we stood up during the pandemic to help us identify where the areas of greatest need was and to guide how we were deploying resources. So we actually use that platform to help us determine where we need to send help, if you will. So in this partnership, we have identified 47 clinics that we can deploy these blood pressure cuffs to. And as we began sort of increasing the dialogue around this issue, a few other partners stepped up. The University of Chicago is interested in really studying the impacts of initiatives like this, as well as Harvard, who also wants to sort of understand the relevance of these sorts of solutions. And here's what we're looking to do. We believe, and I'm a family physician, so I really believe that we can empower and support consumers, health consumers, in being engaged in their care by removing the barriers that exist. So blood pressure cuffs, yes, they're available. Perhaps there's a copay or cost share. Perhaps there's a reimbursement. Maybe in some instances it's a part of your benefits. But forget all of those things. Your physician can now identify you as high risk and in need, and provide that cuff kit from the office. Strengthens the relationship with the provider, engages the health consumer in her care, and creates a longstanding connection that exists throughout the pregnancy. So we're looking to see a reduction in hypertensive disorders of pregnancies, where we are hoping to pick up these cases much earlier. And we're actually doing some subjective surveys around your relationship, your trust level with your provider, which we think is a really key indicator and will help us close some of the gaps that exist in the intrapartum period, in the postpartum period, and then with subsequent care delivered perhaps during pregnancies, but also in other settings.
I love this. And I know it's complicated to execute, but I think the takeaway for me is the strategy is so simple. Focus on a market, expectant mothers, focus on blood pressure, and then figure out where the resistance points are. So if I could summarize what I heard here, you have an SDOH dashboard. It sounds not terribly dissimilar to my Highmark community support that allows you to see individuals who are potentially high risk. That's number one. Two, you purchased the blood pressure cuffs and figured out how to get them to the right place. Those 47 clinics that you're working with. So it's number two, is just figuring out how to reduce friction points, like simplifying logistics around blood pressure. And it sounds like the third thing is you've had some creative partnerships, both with those University of Chicago, Harvard, and also with the Preeclampsia Foundation.
Exactly. Yes.
Yeah.
And I think the other big thing, unspoken, but I want to state it overtly here, is sometimes, very often as a payer, we just have to get out of the way, right? There is not the expectation that everything needs to sort of go through us in some sort of obvious manner. And it's certainly not the expectation of the consumer for the most part.
Just get out of the way, everyone. Come on.
Okay.
All right. I want to shift gears a little bit again, but first, for those of you who are joining us late, the partner for today's episode is Vori Health, Bright Spots in Healthcare. We've been doing this for over 10 years. Can't do it without incredible, great partners that provide expertise and support to the show. Vori Health, if you have not heard or don't know, they are the only nationwide MSK practice with doctor-led teams. And they, as you probably heard from Mary's first answer, got a sense of, they provide a very holistic approach to chronic illness. Their specialty, of course, is musculoskeletal. They provide convenience around care to the back, neck, joint pain, enabling people like that woman we talked about earlier not to have to bounce around the healthcare system, taking a what matters to the patient, what matters to you, we're all patients, approach to figuring out a care plan and then executing on that. Whether members need a diagnosis, non-opioid prescription, personalized PT, or health coaching, they could turn to the Vori Health practice to be able to receive evidence-based care and effective end-to-end support. We really thank them for being a partner of the show. Their model, their whole person holistic model, reduces unnecessary surgeries, enables faster recoveries, and lowers the overall MSK spend for their health plan partners by up to 4-to-1 ROI, folks. So check them out at vorihealth.com. Along those lines, what's key to reducing health disparities is really understanding our biases. And what we don't talk a lot on shows like this is something called treatment bias, which are biases inherent to all of our providers. We probably would all have them if we were treating patients every day. So, Mary, I want you to talk about treatment bias for everyone and what it is and maybe how it plays a role in limiting positive outcomes and what you guys do to mitigate it.
Eric, this is a really great question, a really important question, because, treatment bias is like a dirty little secret in medicine, because bias is part of the human condition. And it's how we make assumptions and choices. But in medicine, it can be a very powerful negative force. And we have lots of examples of this. We know that bias in general is impacting women, individuals of color, those with lower socioeconomic status. And there's, again, numerous studies. If we just look at pain treatment, right? Women are 1.6 times more likely to receive insufficient care for chronic pain. And that is also played out with individuals of color, and particularly those of lower socioeconomic status. And I'll tell you about one study because it's just so fascinating. A man and a woman trained up to be the same, right? Same symptoms, same limitations of function, with moderate knee arthritis, were sent out to all these physicians, primary care physicians, and orthopedic surgeons in Canada. And at the end of the clinical visit, the patient, who is the trained patient, right, basically got the doctor to say, would you recommend if I have knee replacement surgery or not? And the male patient, the orthopedic surgeon, was 22 times more likely to recommend to the male patient than the female patient surgery. Now, we could argue that there's overutilization of knee replacement surgery. Okay, but that's not the point. The point is, why was there such this huge difference in the frequency of recommendation for the man versus the woman? And this study is limited because it was just, 2 individual patients, but there's lots of other data out there that talks about this unconscious bias that we as clinicians have relative to patients. So I want to share with you 3 strategies that we use at Vori Health to combat clinician bias, because remember, we all have bias. One is shared decision-making, okay? And in brief, this means that the clinician is listening to the patient, takes into account their preferences and values, and creates a mutually aligned treatment plan. And I touched on this with the story of Joneigh, right? What matters to you, not just what is the matter with you. The second, standardized forms that gather important clinical information for us so that it helps us to be less biased in considering the right treatment plan for the patient. I'll give you another example. We as a culture, as a society, are basically socialized to believe that women exaggerate their pain symptoms. This is just how we are. And that when a woman says she has 9 out of 10 pain, okay, she's having pain. But when a man says he has 9 out of 10 pain, oh my goodness, he's just miserable. So trying to bring data in to the conversation that helps mitigate these biases is important. And the third thing is that we feel very strongly it's critical to give the patient the right care team. And for musculoskeletal patients, this is a multidisciplinary team led by a non-surgeon, again, with built-in support for that holistic approach that we practice. So we think that these are 3 strategies that have been really helpful for us, effective for us, and things that can be employed, used immediately in the clinical setting. So that's what we're doing. And we really believe that addressing clinician bias is critical for advancing health equity.
See if I capture this mitigation strategy, Mary. That was super great. I live with 3 women. We get into debates about pain all the time. I usually lose. So, one, train your clinicians on the process. Clinicians listening to the patient, taking into account their wants and their values. 2, standardize forms so that there's less bias put into the decision around the right treatment plan. And the third, if I'm hearing you right, is design a process where the patient's looked at holistically and maybe the doctor doesn't come in till towards the end and the plan's already been ironed out a little bit. So we don't get to surgery too soon if we have to go there.
Yes, I mean, we have our patients, we're physician-led, so our patients see doctors, but our physicians are non-surgeons, right? And when we can address health equity better, right, it puts us in a position as a company that to support our value-based care payment models, because we're going to be able to drive more effective non-surgical care, and that permits us to take financial risk. So, you know, there's win-win-wins across the board. Better for patients, better for the clinicians, better for the better, all better.
I want to, like, what I like about this dialogue and the whole theme around treatment bias is it thinks about the consumer first and what the consumer's wants and needs are first. And I want to stick with that theme and move to another example that doesn't necessarily involve gender or race or sexuality, but something completely different, and that's disability. Real quick PSA, folks, in about 9 minutes, you're going to get yet another email from me. It's going to be asking you to complete a 2-minute survey, providing us feedback on this episode, but more importantly, well, equally importantly, what other content we should be covering throughout the rest of the year. That's how this show has grown and grown and grown. That's how we continue to provide value to the market. So your 2 minutes, multiple choice mostly, I appreciate it in advance. Let me know what we could be doing throughout the rest of the year, and our entire team will look at that. Joneigh Khaldun, Dr. Joneigh Khaldun, I want to come back to you and talk about what's an example, as I just teed you up a moment ago, around consumer centricity for a program that's not leaving anyone behind, but maybe doesn't include race or gender.
Yeah, no, I just love this conversation. I have to co-sign what Mary just said as well. I mean, really making sure that the patient is first, and standardization, I think, is really, really important. So you kind of take that bias out of the equation. I think that's a really important point. So, you know, I would say, you know, we do have several programs at CVS Health. We've heard of some programs from our co-panelists. But really, to do health equity well, it's really the lens through which you think about running your business, period. And again, back to this kind of how am I potentially leaving someone behind? And so what are we going to do about that? So I would say to anyone out there thinking about how they do this as a company, if you just asked yourself that question as you're designing or evaluating your programs, I think that would be a good start. So something I'm really, really excited about and proud of at CVS Health, the CVS Pharmacy in particular, is a program called Spoken RX. So we launched this in 2020, and to your point, it's really about how do we think about people with disabilities, and specifically for this program, visual disabilities, where they may have a challenge with reading their pharmacy prescription, something very basic that people who may not have that challenge maybe wouldn't think about. So we launched this in 2020. And essentially, there's a QR code on our prescriptions where someone can scan the code. It connects directly to our internal dispensing software, and it actually vocalizes what the prescription is, all the instructions for that prescription. So we've done that. We've launched it across the country. Over 4,300 patients have utilized this service since we launched, which is really, really exciting. I would also say, again, something very simple, and myself, even as I've gotten older and kind of need those reading glasses sometimes, something that we've done is actually just making our prescriptions for specialty pharmacy in particular, just larger fonts. You know what I mean? Like just larger font. Again, something that people don't think about, but something very basic. Again, it goes back to meeting people where they are and not leaving anyone behind. So that's really something that I'm proud of in our CVS pharmacy.
I love it. I love it. We're running a little bit behind on time. I'm going to get to our next question. Let's see if we could, and then get to our local as a strategy. I know some of you already asked questions about the community. We're going to get there. Mary, I want to bring you back and talk about just in general, when we're dealing with chronic illnesses, and God knows some of us have been in conversations within the last day or two about something called GLP-1s. We're not going to go to GLP-1s, but in general, lifestyle modification has been a very overused term. And when you're thinking about the massive challenge in, let's say, for your consumers who are struggling with MSK and need to start pain, and they need to get involved in PT, and they need to get involved in dietary changes and all these things that are massive changes in their lifestyle. How are you doing that at a population level for underserved people in underserved populations?
So, Eric, this is like the $1 trillion question, right? And, we know that good patients' ability to receive good care shouldn't be determined based on their neighborhood or city or where they live or their proximity to a medical center. So, we're bringing that care to them in the convenience, comfort, safety of their home through virtual services. And I think that's really important. But I want to riff on this a little bit, because there's a difference between medical care. Our patients have an MSK condition. And then there's the concept of how do we promote wellness in a community to improve the population, the health of a population. And I have had the privilege of chairing a national nonprofit called Movement is Life, and we're focused on eliminating health disparities, particularly in the musculoskeletal space. We started a community-based program called Operation Change. We've been running for several years, and I have a learning from this that I'll share. So the program is focused on 50 women for about 3 months. They meet 3 hours a week. The first hour is education, the second, some kind of movement. The third is focused on motivational interviewing in small groups for these women to try and understand what their personal barriers are to lifestyle change, because they all have knee pain and they all have comorbidities like obesity, diabetes, hypertension. We've seen remarkable improvement, 18% improvement in their walking speed, 5% weight loss, and probably the most impactful statistic for me is a 69% improvement in their sense of hopelessness. I mean, hopelessness, okay? And all of this without doctors or drugs or injections. And when we looked at, okay, why is the program working? My original bias was it was going to be the motivational interviewing. But we found out that wasn't the case at all. It was actually that we created a community for these women. We brought them together and created a community, and they then had the emotional support of each other to make the behavior change. And I was like, duh, this is what Alcoholics Anonymous does. This is what all kinds of groups do, because we as human beings need the emotional support to make these lifestyle and behavior changes. And so when we're looking at how are we going to impact the health of a community, I think we need to really start being creative with community-based programs that look at this. And we have taken this learning at Vori to start to create basically online communities of patients so that they can support each other in their journey. That's it.
I 2 gold stars for you here. One is my favorite bright spot. So the host of Bright Spots in Healthcare is telling about my favorite bright spot and what helped inspire this show back in 2014 is Alcoholics Anonymous, and Weight Watchers gets a close second, and the power of peer-to-peer in healthcare. So I'm so psyched you brought that up. Thank you for doing that. And you also created a great segue into our community and local as a strategy segment. So you basically did my moderating for me. So thank you for that.
You're welcome, Eric.
Incidentally, folks, and Sherry, I don't know if we could do this, but if you guys want to tap into just how Mary and her team may advise you guys and to apply a holistic care approach to any of your diseases, especially MSK, but any of your diseases and any of your approaches to whole person care and virtual, and you want to just get an introduction, non-salesy, but like just peer-to-peer, let me know. I'll make a personal introduction. We could put something up, and anyone that says yes, I'll just make an introduction for everyone. Kelli, Tice, bringing you back in from Florida. Let's talk local as a strategy. I must imagine at the foundation of most of your equity programs, you are in different markets around Florida, getting close to the community. How is Florida Blue approaching and executing on this?
You know, I tell people that I waited a long time to love my job, and what you've just introduced is the part of my job that I love the most. We have 5 million plus members, but we believe as a health solutions company that health is local. And so whether the healthcare consumer knows or cares about this or not, we have sort of carved our member population, our state, into these markets. And we have local market integration teams that exist to do deep dives into the data for each one of those markets. But they also work very closely with a position called a corporate social responsibility integrator. So someone who serves as a liaison between the local market team and our foundation, our corporate social responsibility teams. So I mentioned in my earlier response that one of the highlights of our maternal health equity strategy was this partnership we were able to exploit a bit. Well, and that it was initially discovered or created on our foundation side. Well, we do the same thing for all of our local community work. So the integrators ensure that as we identify great partners, community-based organizations that are getting it done and that are doing it well, that they build a bridge for us, for our care teams, so that there isn't anything that's happening in the communities that our members may reside in that our members themselves can't avail themselves of. So that integration is really key. It is, as I mentioned earlier, data is foundational to this. And that is the first place that those local market health service directors look to identify needs in their population. We chose diabetes as one of the first places that we were going to focus because for me, it's an exemplar of health disparities. And as we double click on that, we're able to overlay things like publicly available social determinants of health data in our dashboard, our member data from claims, our cost information, those sorts of things. And we can sort of put a pin in the places where we have greatest needs. And then we can look in the immediate vicinity, do sort of environmental scan and go, what partnerships already exist in that area for us? What CBOs are we already working with? What partnerships are needed? Where are retail partners? What pharmacies do we need to partner with? We applied this during the pandemic with our COVID vaccine initiatives. We do it every year with our flu vaccine and other respiratory illness initiatives. And we do it for our chronic disease approaches, primarily diabetes. And it works. And it is something that now is ingrained into our team approach. And as we accomplish this and see the impact and outcomes, right, we now can identify the next condition we want to look at, be it asthma, be it sickle cell disease, be it cancer, because the model really lends itself to the deployment of the solution using that particular approach. It's phenomenal. The growth that has occurred as we have as we've deployed this, and in fact now our foundation has begun to more intentionally align their funding opportunities based to align with the needs of the community, so that we can yet increase our impact. So it's really been tremendous, and as you can tell, it's the thing that's most fun about my job.
Well, I have a follow-up. So, obviously, Florida Blue, big company, has a lot of resources. Community-based resources have limitations. How are you guys investing in the communities in these markets and investing in the CBOs and making this all work?
So important. So, one of the key ways is to, as I mentioned, we do a lot of grant funding. We deploy a lot of grant fundings in our communities, and we actually come together as a team to determine what areas or issues in the community we'd like to impact. because of a position like mine, we now know to coordinate with the community health improvement plans that might exist in the communities we're trying to impact, or other local initiatives. There are a lot of purpose-built communities, for instance, that have work underway, and we want to come alongside that. So, that initial environmental scan is very important, and it drives what we fund. One of the things we identified, for instance, was this need to help CBOs look at things like pay equity and diversity and inclusion in their own leadership teams and staff, to look at training for health equity, making that available to them, those sorts of things. And our foundation is able to lean in and do that sort of thing. It sits in a program that we launched a few years ago called Growing Resilient Communities, where we identified 6 key zip codes where we really wanted to make an impact. And it's really grown from there. The thought is, by standing things up, creating an infrastructure of financial independence, addressing social barriers and needs, looking at disease burden, supporting community-based organizations, looking at employment, funding STEM training and providing scholarships. If you do all of that, sort of plug all the holes, that the community can sort of right itself, and then you've created a sustainable change that will, in the long term, result in better health outcomes.
I love that. Love that strategy. I want to stay on that line of thinking and bring in Nebeyou real quick, folks. Next week, we have another episode. It won't be live, but it will drop on Thursday. And it features another Chief Health Equity Officer, Dr. Allison Bryant at Mass General Brigham. And she's going to talk to me about how Mass General Brigham is innovating around equitable access. I've actually already had that conversation. I'm going to tell you, super interesting and right in line with the topics today. So subscribe to the podcast to get that. May 23rd. Next, we're going to switch gears a little and talk about commercial outcomes, strategies for health plans to mitigate social risk. And that's going to feature the Chief Health Officer at Elevance. It's going to feature the Vice President of Clinical Services of Blue Cross Blue Shield of South Carolina, President of Business Group on Health. So really great group there. If you want us to register you for that event on May 23rd, that'll be live, just like this one, 12 p.m. East Coast time on Thursday, May 23rd. We'll register for you. Just click on that poll right there. So Nebeyou, same kind of question. How are you partnering with CBOs, and how are you also enabling providers and other stakeholders to take advantage of these organizations, and how are you actually kind of investing in the community?
Sure, that's a great question. And I'm going to pick up on what Dr. Tice just mentioned about sustainable change. That's what we're really focused on at Highmark, is really operationalizing this work so that we can see that sustainable change and truly address health and healthcare disparities and inequities. So to answer your question, in 2022, we launched what we call a high-performing social care network, where we are financially incentivizing and reimbursing community benefit organizations for the critical role that they play in addressing and resolving health-related social needs. What makes this program unique is that, historically, I mentioned earlier, we have the assessment, we have the resource and referral platform that connects our members to local care and resources to address their needs. We also have other types of social care interventions, but the ones where we direct our members to CBOs, historically, we haven't gotten data back from the CBOs after we make the referral, right? So when you think about prioritizing the care plan, particularly for those members that have health-related social needs, it's unrealistic to think that they can, manage their A1C when they're struggling with food insecurity, have transportation issues. It's unrealistic that they're going to be able to adhere to their medication, et cetera, et cetera. So really focusing on those basic needs and addressing those first, and then, should trigger the next best action to engage in those clinical and behavioral health programs. That's how we think about whole person health and whole person care at Highmark. And so this program that I'm talking about is critically important because we get the data back from the CBOs, and then that triggers the next best action once social needs have been resolved for our case management team and social workers to then intervene and to provide the right level of care at that moment. And so we initially started with 20 CBOs that are in this closed network. Now we've increased it to close to 40. And the clinical staff and CBOs communicate via the community support platform, which enables better care coordination and ultimately improves the health of our members and patients that are served through that. In terms of the sentiment back we're getting from the CBOs and the providers that are involved, 98% of the participating CBOs noted they would recommend this program to other CBOs. 90% of participating CBOs felt this program enhanced communication between their organization and the healthcare sector. And 93% of the clinical teams surveyed felt this program added value to their teams. And I'm sure, we're all hearing about the federal mandates from CMS and NCQA, which are where they are, enforcing mandates for providers to assess, refer, and soon they're going to be tracking whether or not the social needs have actually been addressed. So this body of work is critically important to us as a plan and a provider. And so we're really excited about the early results. We're looking to expand this program in other markets. As you know, we're in Pennsylvania, New York, Delaware, and West Virginia. So we're looking to expand this model. In terms of the secret sauce, I would say, our team works very closely with our CBO partners to help onboard them and adapt workflows and processes together, which, we talk a lot about trust and capacity building. That's always been our focus and priority. We've also had to refine and adapt the model to move forward towards paying more for outcomes. And so the CBOs get paid for addressing the social need and then closing a loop, sending the data back to us. And so just a quick example of how this work is helping our members. There was a 72-year-old woman who was experiencing difficulty getting to her chemotherapy treatments. The Social Care Network connected her to Travelers Aid, which is a local ride-hailing Uber and Lyft service organization, allowing her a safe, convenient, and burden-free ride so that she can attend her crucial medical appointment. So that's a huge success story. Historically, we weren't aware of that information, and now that we know that her transportation needs has been addressed through the CBO, we can then engage her in other clinical and behavioral health programming that she may be available and can access. So really proud of that work, and can share more information with the audience if there's questions about it.
Right, love this stuff. I know you got some other stories. We may have to save it for another episode because we're kind of cut in time. But I want to bring back in Dr. Joneigh at Khaldun. How are you guys at CVS Health integrating CBOs into your health equity strategy?
Yeah, absolutely. I would co-sign what my co-panelists have said, really making sure you're data-driven, putting the community first, and then I forget who said it, but getting out of the way, right? Like we as organizations, we have a lot of resources, but we don't need to be at the head of the table. I spent a lot of time in governmental public health and even in those roles, right? Like you don't need to be at the head of the table, let the community be at the head. So one program I would highlight, something I'm proud of, is our Community Equity Alliance that we launched in January of last year. And the goal of that initiative was really for us to partner with healthcare organizations and institutions with a robust experience working in and serving underserved communities and populations, and with a very specific goal, which is building out and supporting the community health worker workforce, which we haven't talked about too much today. Maybe that's another episode, but also leveraging that workforce to address heart health and mental health disparities. So our first organizations, Wayne State University in Detroit, Sinai Chicago, Meharry Medical College, a historically Black college and university. We already, in a year, trained over 50 community health workers. We've already actually completed a robust community health assessment, or qualitative analysis of health needs in Detroit, listening to people with lived experience in the city of Detroit, not people who are looking at numbers and saying what the challenges are, what the solutions are. And then we're also already starting to integrate those community health workers into clinical care teams, building on trust and really making sure we're addressing those disparities. So I know we don't have a lot of time. I could talk all day about this, but I'm really proud of the work we're doing. And especially just want to give a shout out to community health workers and the importance of them when we talk about the healthcare workforce.
And you calling that the Community Equity Alliance, right?
That's the Community Equity Alliance, yes.
We'll try to do, and we'll talk about this once we stop recording, getting some of the links to all these programs mentioned into the show description for everyone. I really appreciate all of you. You did a great job. Thank you for all the time you took. To everyone listening, do not take the time you spend with us for granted. So thank you for joining us. My message to everyone is a problem may look hopelessly complex, but rather than looking for a massive cover to fill a massive hole, use the strategy of finding bright spots, things that are working among all the chaos, because these tactics could generate unbelievable progress and maybe an entire solution strategy to your toughest challenges, like health equity and chronic disease. So I hope you use the bright spots shared today to inspire your thinking, maybe even copy one or two. We produce this show for you. Remember, this is your Bright Spots in Healthcare podcast. Thanks, everyone.